Hello and welcome back to the training series on child growth assessment. In this segment, we will discuss Module B Part 2, which is dedicated to measuring a child's growth. In this video, we will cover the following topics: recognizing clinical signs of marasmus and kwashiorkor, measuring and recording a child's length or height, and calculating the child's BMI using a calculator. When undressing a child to weigh them, it presents a valuable opportunity to observe for signs of malnutrition, such as marasmus and kwashiorkor. Marasmus is a severe form of undernutrition characterized by a significant loss of muscle and fat, resulting in a wasted appearance. A child with marasmus may appear extremely thin, resembling skin and bones, with prominent ribs and sagging folds of skin around the buttocks and thighs. If marasmus is suspected, the child must be referred for urgent medical care. Kwashiorkor. Another form of severe malnutrition is associated with edema or swelling, and also requires specialized care. In kwashiorkor, generalized edema occurs due to fluid retention. The child may have a rounded face because of the swelling and there. Hair often appears thin, sparse, or discolored. The skin typically exhibits symmetrical, discolored patches that may later crack and peel. Edema can mask the true weight of the child. If a child's weight falls within the underweight category while exhibiting edema, or even within the normal weight range with edema, the child is still considered severely underweight, as the edema obscures the actual weight. Therefore, it is crucial that children presenting with edema are referred for immediate, specialized care. In some cases, a child may develop a combination of both conditions, known as marasmic kwashiorkor. While marasmus and kwashiorkor are usually distinct, a child with severe undernutrition may exhibit features of both, such as severe wasting seen in marasmus, alongside the skin and hair changes or edema, typical of kwashiorkor. Edema in both feet is a key indicator that the child requires referral, even if no other signs of kwashiorkor are present. To check for pedal edema, place the child's foot on your hand and gently press the top of the foot with your thumb if edema is present. A pit will remain when you lift your thumb. When measuring a child's length or height, it is important to first explain the procedure to the parent or caregiver. Height is measured with the child standing upright, while length is measured with a child lying down. It's two types of measuring. Boards are used, a length board and a height board. If the child is younger than 2 years, measure their length. If the child is 2 years or older, measure their height to convert length into height. Subtract 0.7 centimeters from the measured length. This adjustment accounts for the difference caused by the spine relaxing when lying down versus compressing due to gravity when standing upright. To measure length, use a length board. To measure height, use a height board. Let us watch a little clip showing us how to appropriately measure the length and height of a child.
Length is measured on a Harpenden infantometer, which has a fixed headboard and movable footboard. To avoid causing discomfort, cover the board with a thin cloth or soft paper. The lead observer stands on the side so as to hold down the baby's legs with one hand and move the footboard with the other hand. The assisting observer stands at the headboard to help position the child's head. Braids should be undone and hair ornaments removed if they interfere with positioning the head. The assisting observer holds the child's head so that the top of the head touches the fixed headboard. To keep the child's head in the correct position, she gently cubs her hands over the child's ears. The mother reassures the child and talks to her. The head is positioned so that a vertical line from the ear canal to the lower border of the eye socket is perpendicular to the horizontal board. This position is known as the Frankfurt vertical plane. The lead observer positions the child's trunk so that it is flat and straight on the board. Gentle pressure is applied on the knees to straighten the legs. The footboard is positioned against the child's feet, toes pointing upward. Measuring length can provoke anxiety and crying in children, so the mother should reassure the child. It may be necessary to keep the child's clothing on, but ensure that they do not get in the way of the measurement. Her head should be positioned correctly, and her legs and feet held firmly in their correct position to obtain an accurate measurement. You may wish to encourage the mother to take the time to comfort the child after the measurement. For newborns, position their head as you would an older child, but it is not possible to straighten the knees of newborns as with older children. Newborns are still very fragile and could easily be injured if too much pressure is applied to their legs, so the observer should apply minimum pressure on their knees. Position the head, straighten the child's trunk and legs. Position their feet. Then record the length in centimeters to the last completed 1 millimeter. A Harpenden stadiometer is used to measure height. The stadiometer has a vertical backboard, a fixed baseboard, and a movable headboard. In measuring child height, the assisting observer holds the child's legs to keep them straight and feet flat. The lead observer must get down to the level of the child's face. The child stands on the stadiometer with feet slightly apart. Hair ornaments should be removed. The back of her head, shoulder blades, buttocks, calves, and heels should touch the vertical board. Position the head so that the horizontal line connecting the upper ear opening and the lower edge of the eye socket runs parallel to the baseboard. This is the Frankfurt horizontal plane. Push in gently on our tummy to help the child stand to full height. Pull down the headboard to rest firmly on top of her head. Take the reading to the last completed 1 millimeter. Remove shoes and hair ornaments. Stand against the vertical backboard. Position the head. For adults, they should take a deep breath. For children, push in their tummy. Record the height in centimeters to the last completed 1 millimeter.
All equipment must be stored safely, and its accuracy must be maintained consistently. Accuracy checks should be performed at the time of purchase or upon receiving new equipment and should be verified weekly. Weighing scales use weights of known values, for example, 3 kilograms, 5 kilograms, 10 kilograms, or 20 kilograms. To ensure the scale reads accurately, for example, placing a known 3 kilograms weight on the scale should yield a reading of exactly 3 kilograms. Length and height boards. Verify accuracy using rods of known lengths, for example, a 50 centimeters rod. The board's reading should match the known measurement. Exactly, if any equipment is found to be inaccurate, it should be calibrated. If calibration is not feasible, the equipment must be replaced. To calculate a child's body mass index (BMI), use the following formula: weight in kilograms divided by length or height in meters to the square. A calculator is recommended for accuracy. Additionally, a BMI table is available in the annex of Module B and provides a quick reference for determining BMI. Instructions for using the table can be found in the reading materials of Module B. This concludes Module B. Thank you for your attention. We'll continue with Module C in the next session.